Good morning. I am Raquel Gonzalez, and I am going to talk about hypotension prophylaxis with ready-to-administer phenylephrine. This is me. I am an anesthesiologist from Madrid in Spain, and I have been practicing obstetric anesthesia for 6 years now. This is going to be the index of the topics to discuss for the next 30 minutes. And I wanted to start by presenting this document. This is the International Consensus Statement on the Management of Hypertension in C-section. It was published by Gonzalez in 2018, and it's nowadays the most important document in this topic and the guideline to follow. I am going to start by defining hypotension and reminding its physiology. Well, there have been a lot of different definitions of hypotension, and this made it very difficult to unify criteria both for investigation and for recommendations. So Gonzalez in the International Consensus Statement is going to define hypotension as a decrease of blood pressure below 90% from baseline. And he is going to add that we should always be avoiding a decrease below 80%. Well, and about hypotension after spinal anesthesia, let's review the physiology of blood pressure. Well, we know that blood pressure is determined by systemic vascular resistances and cardiac output. Cardiac output is going to be determined by heart rate and stroke volume. On this side, systemic vascular resistance is by all of us understood like vasodilatation or vasoconstriction. And what is going to happen after spinal anesthesia, especially in an obstetric patient? Well, we're gonna have a decrease in stroke volume, but the most important thing is going to be the vasodilatation that we are going to provoke and the decrease in systemic vascular resistances. Well, we know the importance of hypotension in all of our patients, and we know that we should have normotensive patients in our whole clinical practice. But in obstetric medicine, this is twice as important, and we should keep in mind that we are also taking care of the neonate and that our actions are going to have serious consequences. And thinking about this, it seems clear that duration of hypotension might be more important than severity. And here I wanted to leave you with 3 studies that showed this fact. It seems clear that transient decreases in blood pressure, like smaller than or shorter than 2 minutes, did not really affect the neonate, but periods of more than 4 minutes hypotension may have important neurobehavioral changes at 4-7 days of life. So here we have the first clear thing to our practice from evidence, and it's that we have to do an early diagnosis by continuous talking to the mother or taking non-invasive blood pressure every 1 minute. That is the recommendation. We have to do early treatment, or better, we should prevent hypotension from happening. And this is the concept of prophylaxis that is going to be repeated in this presentation. Well, what tools do we have to prevent hypotension? Well, we have 3 big tools, and in my opinion, it's very important that we combine them all and we don't forget any of them. About non-pharmacological measures, they aim to reduce inferior vena cava compression and venous pulling of the legs. We also have to adjust the doses of the spinal, which is going to be very important because this is going to be determining the degree of vasodilatation that we are going to provoke. And next we have fluid administration. Nowadays, the indication is to do a colloid preload or a crystallate colloid. And in the third place, and the most important place, we have vasopressors. Well, it seems clear that given that vasodilatation is going to be the effect provoking the most degree of hypotension in the C-section after spinal anesthesia. Vasopressors with predominant alpha agonist activity are going to be the correct choice to reverse these effects of the spinal. And between them, phenylephrine has the most evidence supporting its use. Well, let's go to vasopressor choice. It's difficult to compare in such little time all the vasopressors that we have to use, but I want to talk especially about phenylephrine and what makes it special and adequate for this environment and this scenario. Phenylephrine is a pure alpha-1 agonist, and it has a direct mechanism. So it's going to have an immediate set of action with an intermediate duration. And I'm not going to get a lot into this, but I wanted to talk about the comparison between ephedrine and phenylephrine, because ephedrine has been widely used in obstetric anesthesia for a long time. And this is mostly because first studies were made in animal models with sheep. Once we started to study vasopressors in the human pregnant woman, we started to see these 4 big reasons with a lot of evidence in each of them. And I wanted to show you a little study, or leave you a little study of each of them. The first one is that it is more effective, as we see here in this study from Dyer. The second is that it has less placental transfer than ephedrine. It has improved fetal acid basis status, and it has not demonstrated a deleterious vasoconstriction. This is said by Nganki in this study, favoring phenylephrine. And then, now that we know and we have seen why we should use phenylephrine as a first choice vasopressor in obstetric anesthesia, let's see how to use it. And here we are going to try to answer to a lot of questions on this subject. And let's go to it. Well, the first question is if we have to be prophylactic about hypotension, or we have to treat it when it appears. And this seems very, very clear that prophylactic treatment has demonstrated benefit over reactive treatment. So Kinsella is going to say and to tell us that we have to start vasopressors immediately after the insertion of the spinal. This is going to be in line with what we were saying before, that we really have to avoid hypotension. We should not let it happen. Well, the next thing, and this is more controversial here, is if we know that we have to do prophylaxis, should we do it with boluses or with continuous infusion? Well, several studies in all these years have indicated that infusion is more effective than a boluses regime. And this also is important to talk about, because all these studies compared infusions with very low doses boluses. So, well, this is the data we have, and it's important to know it. But recently, we have had other studies made by very expert doctors in this subject. And when they compared continuous prophylactic infusion with prophylactic boluses of phenylephrine in more adequate regimens, prophylactic boluses showed to be as effective as the continuous infusion. And of them, I wanted to show you this study by Doherty that showed that there were no clinical benefits when they compared boluses of 120 micrograms versus an infusion of 120 micrograms per minute. Well, let's go to the optimum dose, and then here again, most of the studies have been made with infusions, so this is going to be the optimum dose that we are going to talk about. And the indication is to start the infusion at a rate of 25 to 50 micrograms per minute and titrate it to the response. And this comes from here, a very big study made by Allen, where compared non-infusion, 25, 50, 75, and 100. And he said that 25 and 50 micrograms per minute were the best profile in preventing hypotension without reactive hypertension and maternal bradycardia that did appear in higher rates in these two groups, in 75 and 100, and of course better than not having an infusion or not administering phenylephrine. Well, one thing that worries about phenylephrine is heart rate, and we know that phenylephrine can cause a decrease in heart rate, usually a baroreflex mediated bradycardia, and we also know that this can cause a decrease in cardiac output, and we can see it here in this graphic by the study from Dyer that I left also before. And this can be measured in such numbers, so up to 20%. So this could be worrying. Well, the thing about this is that for me, it's important to know when I use phenylephrine that this decrease in heart rate and cardiac output is going to be dose dependent. And what Stuart says in this study is that this reduced heart rate may indicate excessive phenylephrine doses that cause a reduced cardiac output. So when we adequately use phenylephrine, we should not have a decrease in heart rate and cardiac output. And then again about this, even though bradycardia can appear, what is its clinical relevance? Well, a large study said that bradycardia may not be a problem in healthy young women with healthy fetuses. Anyway, if bradycardia appears, what should we do? Well, this bradycardia produced by the baroreflex after phenylephrine usually responds well to anticholinergic drugs or to ephedrine. We have to be careful to administer atropine, for example, that is what I use, because these drugs could be responsible for hypertension, headache, or bigeminy. So they say that in the international consensus statement, they say that we should only use it if we have bradycardia accompanied by hypotension. And what is the threshold to use atropine? In what heart rate should we run to administer atropine? Well, there is no evidence to indicate the heart rate threshold requiring treatment in the absence of hypotension. So they leave it to our individual clinical judgment. Well, let's go to how to use it, like to this guide of how to use. And this comes directly from the international consensus statement from Kinsella. The first thing they say is that we have to prepare 10 milligrams of phenylephrine into 100 milliliters of saline, and this gives a concentration of 50 micrograms per milliliter. I do not really prepare this medication or this dilution because I use a ready-to-administer syringe that already gives this concentration, that is the recommended one. So this is widely convenient for me because I never have to be making these dilutions. Well, as we have been talking, the infusion is for now it's a recommended regimen to administer. So if we have a pump available, we should administer the infusion starting at 50 micrograms per minute, and we should try to do it to effect. Another thing that we could do is start it at 25 micrograms per minute and treat hypotensions with boluses of 50 or 100 micrograms, which would be, with our ready-to-administer syringe, would be 1 or 2 milliliters. What do we do if we do not have a pump available? Or in my case, because I am used to doing this and we have sufficient evidence to do it in a bolus regimen is to not use an infusion and administer bolus as required, and the doses would be 50 to 100 micrograms. That again would be 1 to 2 milliliters. And what I do is to start immediately after spinal, but also they say that we could start treatment with heart rate increases or blood pressure decreases under 90% from baseline. This is another algorithm, and it's exactly the same, but I wanted to show that this regime of boluses is widely accepted in other guidelines that are also very high quality guidelines. This one is for Nguyen and edited by Professor Mercier. Well, and let's sum all this up in this user guide that I wanted to give you in this presentation. First thing would be that the objective of blood pressure in C-section, undergoing C-section under spinal anesthesia, would be to maintain blood pressure above 90% from baseline, never let it go under 80% from baseline, and check blood pressure every 1 minute. This is the recommendation, and I would leave it to you for discussion to think if 3 minutes interval of blood pressure, non-invasive blood pressure, would be acceptable. The next thing that is clear is that we have to be proactive and we have to use vasopressors prophylactically, and this is clear. About continuous infusion or prophylactic boluses, we know that continuous infusion is the preferred option in the Gonzalez guidelines, but prophylactic boluses also have sufficient evidence to be recommended. Then if we use an infusion, we should start it at 25 to 50 micrograms per minute, with or without top-up boluses, and also at top-up boluses when needed, or titrating the infusion. Just to finish, I wanted to remember that we always have to have one eye on heart rate as a surrogate for cardiac output, and if heart rate decreases, we should decrease the infusion. Well, and let's get to ready to administer syringes in this context, and here I would like to share a little bit from my experience and maybe get a little more personal. Well, I want to start by what do we know so far, or what I see in my practice, and what evidence says, and what we can do about it. Well, the first thing is that we should choose phenylephrine over ephedrine in C-section, and this is clear. But the second is that we have noticed that some healthcare professionals might feel uncomfortable using phenylephrine, even though they know it's the first choice vasopressor and they should be using phenylephrine in the obstetric patient. What I suggest, or what I think about it, is that what we have to do is use it right. I think we have to provide ourselves with tools that make it easy for us, make it safe, make it friendly, and that we have very clear how to use it, what to do if things happen, and how to use it right to avoid these things from happening. So for me, it's important that we have very clear protocols about this. Well, and then I wanted to talk about why ready to administer syringes here in the obstetric environment. Well, what I think is that phenylephrine is a safe drug, but problems could come, as we were saying, about the doses and excessive doses when we make errors. About the environment, the obstetric ward, I think we all know it. It's a place with stressful circumstances, a place where often more than one healthcare professional is involved, and where mistakes have very serious consequences that we all want to avoid. And just to finish, why we should use ready to administer syringes, because international consensus says so. explicitly. They say that single dilution techniques or prefilled syringes should be considered. I wanted to continue by showing you this study. This study is from my country, from Spain, about declared incidents with medication. And for me, it was very interesting to read it, because here in this line, we have a growing number of incidents declared, and here the seriousness of the mistake or of the error with the percentage of incidents with morbidity. And I wanted to bring out that vasoconstrictor agents are one of the most frequent medications involved in incidents declared. And on the other side, we have that wrong dosage is going to be one of the most serious, or the incidents with more morbidity that we find. So here, when we are administer vasopressors, we have to be avoiding this, because it's going to be frequent and it's going to be serious. Well, here I wanted to show this table about advantages of ready-to-administer syringes, and I think there are plenty, and all of them, of course, are very important. But what makes me a strong supporter of ready-to-administer syringes is safety. And what I think about safety is that we anesthesiologists have been leading safety in medicine for a long time, with our simulations, with our checklists and everything. And I think that avoiding errors in medication is mandatory in this pathway. And I think that ready-to-administer syringes are mandatory to use if we have it. I mean, if we have a tool like this, we cannot afford to make an error because we are not using it. And just to finish with this, and to close this about medical errors and ready-to-administer in relation with them, is that we have here this study that shows that ready-to-administer syringes help reduce errors at such quantity as more than 70% of reduction rate. So we have this opportunity. Is my opinion that we cannot lose it. Well, just to close my presentation, here are the conclusions. Well, the first is that phenylephrine is the first line vasopressor in hypotension after spinal anesthesia for C-section. This is very, very clear and very well demonstrated. The second is that we have to have our patients above 90% from baseline. This is the objective blood pressure. And the third is going to be that we have to be proactive in preventing hypotension, and we have to administer vasopressors prophylactically. The last one is that, as said in the international consensus statement, single dilution or prefilled syringes are recommended. Thank you very much for your attention, and good morning.